morning, everybody. Thank you, Mr. Chairman. On behalf of Dr. Hussein Al-Amri, who asked me to do the task, he's the moderator of this topic, which is optimized management of left main coronary artery disease in the Gulf region consensus. And you can see the Hussein Al-Amri is the moderator of this. And there are a lot of listed panelists from different Gulf region are involved in making this consensus. I must say that the consensus is not easy. I've been involved and I've been asked to give 3 chapters, which I will show you some of them. It took me more than 10 months to do these 3 chapters, so it's a very tough task that has been given to us to do it, to show it to you what is the best consensus that we will come out. But I must say also emphasize that the theme of the consensus is unified among the consensus group of different topics, i.e. we will vote and we have the strong recommendation and then the other moderate or weak. But until now, Dr. Hussein said we haven't sit together to finalize the voting. So the primary data that I will show you, and we are going to do it because left main is a very huge topic and it is a long journey to finalize it and issue it. And inshallah we'll finish it very soon in the in the same manner and theme that other colleagues of different topics did it. So what are the rationale behind doing this? Is they represent the left main, highest risk of coronary subset, require a precise decision making, and there is a critical need to bridge the gap between global evidence and regional practice. As you know, in our region, we'll address specific issue like high diabetes prevalence and resolve the contemporary debate on the imaging and physiology and harmonize the practice pattern across the region. Now, the objective, ladies and gentlemen, of this is to establish a unified evidence-based consensus that serve as a practical guide for us, for clinicians, for everybody who are involved in dealing with the left main disease. Standardize the assessment. We made, of course, everybody will do the algorithm, and we are making for the imaging and physiology and their role in the left main. Also optimize the revascularization for whom should go for PCI and whom should go for bypass surgery. And also refining the technique, and we will do some of the step-by-step based on the evidence that in the literature of same of the technique of doing some of the procedures in the left main disease. So the methodology and the framework, ladies and gentlemen, the evidence, of course, we did a systemic review of major randomized controlled trial and registry over the last 3 decades, comparing the outcome of the bypass and PCI, and also the guideline analysis is the critical comparison between the European and American guidelines to identify the discordance and the consensus specifically regarding the revascularization class of recommendation. Then the expert will come after reviewing all the regional expert assigned to specific domain and chapters to read, and then as the other, we will sit again together to vote and then to do the first draft, second, and then we reach to the finalized recommendation. These are some of the important topics that we were involved. I wrote the 3 chapter of dual antiplatelet therapy, mechanical circulatory support, and complication of left main. This is my task. Other colleague, they did the overall of left main disease management strategy, specific population in dealing with left main, particularly the elderly, heart failure and diabetes, and the society guidelines for left main. Somebody is having the task to do all the guidelines available left main, and others are comparing between the different guidelines of American and the European, and what are the gaps in evidence of future direction. Again, we went into details for professional stenting strategy and two-stent strategy and the criteria for optimization. And also, as one of the surgeons in the region with us, he was asked to give us or wrote a chapter on minimal invasive and emergency bypass surgery in left main disease. This is some of the points. This is from my involved topics that I made it, and I wrote the consensus. Still, we are not voting like my colleague. They are advanced behind us. Of course, we made it, and then we'll set to vote for this and giving the level recommendation. But some of the points for consensus is that we advise strongly to use the latest generations of DAS in left main disease, not a bare metal stents, for instance, and define complexity of PCI. These are the we make definition of what we mean when we say complex left main disease. What are the definitions or the criteria of high-risk patient? What is the definition of high ischemic risk patient and high bleeding risk? And the most important is the past DAPT treatment in the left main, and the very important when we review, and I did review extensive the literature to see whom of the type of the population that we should extend the dual antiplatelet therapy in left main beyond 12 months, and I have listed mainly taking from the COMET registry, which is the Korean registry, of whom should we go beyond 1 year. Now, I created this algorithm. It took me a lot of time to do it, an effort. And one thing I did it, and I really want to share with Mr. Chairman that for the first time, and we are glad to do this, the first time we have incorporated the imaging modality, which is not there in any algorithm that I have reviewed in the literature. So I came with the concept that we should put the algorithm of imaging modality done, either IVUS or OCT or not. If it is done, then we will make it short as possible, depending on if it is high ischemic risk or high bleeding risk or mixed between bleeding and ischemic risk. And if the imaging modality done, you make sure that if with a high ischemic risk, then you go with the default strategy of 1 year. However, if you don't do imaging modality for reason or another, you are in a peripheral, you didn't have facilities, then to extend, we're giving a guide to how to extend your therapy based on the imaging modality and sim. So this is really took a lot in the case of acute coronary syndrome as well as in stable coronary artery disease. Then we are proud to input this modality in our algorithm. Few points on the mechanical circulatory support. Again, we will explore the purpose, the high risk, who should benefit, indication, benefits evidence, and the decision making. And again, these are some points from my colleagues. I took it for the left main bifurcation. They started to say the evidence, the role, and then at the end we will write the consensus of doing this two-stent strategy, and then we will make the voting system. These are the two-stent strategy, the technique, the steps, and again we will set, my colleagues wrote these chapters, so they are giving the task again to do the final consensus so we can approve it. This is some of the lists of complication, major complication, acute, whether it is a cardiac or non-cardiac complications. So, Mr. Chairman, dearest colleague, what is the current status that we are on behalf of the moderator of this? The available data have been shared with the medical writer for the first draft and then the next step is, as we said, to write, after voting, to write the boxes of recommendation, and hopefully that we will sit again and write the final draft, and hopefully to finalize the final manuscript for publication. I must say this is the first time in this consensus, and it's very tough and task, but I'm sure our team are capable of doing it, as shown by my colleague, Dr. Mohammed Kirdi, how they spent time and effort. This is a huge time effort. It's very difficult to collect all the panelists to share and go into Zoom meeting to vote for this. But I can assure Mr. Chairman that have a future vision that, Mr. Chairman, we will do it and we will finalize it for you hopefully very soon. Thank you very much for your attention.